questions. But Rosie broke all that by bringing us such great entertainment to wake us up. So I'll take us through this last talk of the day. And the beauty is that a lot of what I'm going to present has already been presented. So we'll be going actually down just memory lane, and the memory is for today's sessions. So as you keep seeing my slides, you'll also be seeing a lot of the slides that you've already seen in the previous talks. So we'll be discussing the triple win in diabetes care. So what's very interesting is probably 2 years ago, I gave a very, very similar talk talking about the dual combination therapies, and that's when we just had the introduction of the dual FDC, the fixed dose combinations of the dual therapies. And now I'm privileged to be again on the same podium talking about the triple combination therapies. So we have been evolving in the field of diabetes, and in our country we are privileged to get the opportunity to get access to this kind of combination therapies. Today we have already learned a lot about the benefits of early combination. So like I said, we are going to actually be browsing through the talk. So just relax and take in repeatedly through what you have already done in the morning. So this is going to be the layout of my presentation. We'll look a bit at the introduction on what this whole concept is about. We look at what is the benefits of early glycemic control, the role of early combination therapies, and then the role of triple combination therapies. And then of course we conclude. So this you have already heard, about 500 million people across the globe are actually living with diabetes, and it is the leading cause of mortality through the world, with all the figures from all the different bodies showing the same kind of percentages. And of course cardiovascular complications are the main cause of mortality in diabetes, as you can see. Peripheral artery disease, heart and brain involvement with vasculature in the different organs, causing the major impact of cardiovascular mortality. If we move on, we also know that diabetes is associated strongly with comorbidities like heart failure, kidney failure, and atherosclerotic cardiovascular disease. And you see through this Venn diagram that these conditions are actually inter and overlapping. And there is the percentages within them, as you can clearly see. And that is the combination that we are looking at, which we want to hit with our therapeutic approaches to diabetes. If we look at the hemodynamics in diabetes, we can see that diabetes affects the heart in different ways by affecting the cardiac preload and the afterload, and directly affecting cardiac musculature. So what is very interesting is, before we used to think that diabetes affects the heart through macrovascular disease only, and thereby causing ischemic cardiomyopathy, or contributing later to reduced ejection fraction, so heart failure with reduced. But now we know that the microvasculature that is affected by diabetes directly affects the myocardial cells as well, and the vasa vasorum supplying the coronary arteries. And so it is a different way, not only through the macrovasculature, but also through microvasculature, that you can get cardiac involvement in diabetes. In the kidney, Dr. Soki has already talked a lot about it, so I'm not again going to go into the details, but we know that there is the element of upregulation of your SGLT2 receptors. In diabetes, there is increased intraglomerular pressure and disturbances with your RAS pathway. And in the circulation, as you can see, you have your increased volume expansion, vasoconstriction, and blood pressure. A study we did locally, actually in our facility, showed that about 25% of patients with diabetes have hypertension. And this was just in our DKS study, which is more combined type 1 and type 2, but the figures are obviously more in other setups, but there is definitely a strong link with diabetes and hypertension, as we all know. And all these pathophysiologic processes therefore then contribute to your cardiac and renal complications of diabetes, as you can see. There is also the huge element of heart failure that we have already discovered today, we have seen. Now we started with an the triad that we were discussing, the traditional triad, which moved on to the ominous octet in the pathophysiology of diabetes, as you can see, by DeFronzo et al. However, we are now looking at something known as the egregious 11, where the beta cell is actually the construct, the final common denominator is beta cell damage. However, today you have heard from so many talks, from Dr. Rosalind's talk, from the rest of the talks, that there is multiple pathophysiologic processes involved in diabetes, whereby you've got the pancreatic beta cell, but the alpha cell is also coming in. There is the issue of incretin effect, which Dr. Eric very nicely pointed out. The amylin aspect is there. Immune dysregulation. There is the element of the colon microbiome, as was brought out very clearly in one of the talks today. The brain involvement is also very crucial. The whole aspect of adipokines and their derangements in diabetes has been postulated also to play a role. And your stomach. And of course, not forgetting Dr. Soki and the rest of our nephrologists, the kidney. So it's a multiple pathophysiologic process, and of course insulin resistance is also one of the cornerstones of diabetes pathophysiology. And this slide again was presented that we know by the time you are diagnosing diabetes, already the disease has been in your body for about 3 to 7 years or even more. And you could have already developed some micro and macrovascular complications. And what's interesting is that about 50 to 80% of your beta cell mass is actually lost at the time of diagnosis. This could recover to some extent as the disease process goes on with your therapeutic approaches and the lifestyles and all. But then there is again a gradual decline of about 4% per year. If you look at the natural history and even with medication, as we shall see. So what about early glycemic control? Again, a lot has been said. Mine is to just summarize. We know that the UKPDS, the DCCT trials actually showed significant benefit in reduction of microvascular complications in the long run, and when the trial was followed up, actually showing reduction in macrovascular complications as well. In the UKPDS, even with the metformin group, actually there was a reduction in myocardial infarction with early intensive therapy. And this is due to the metabolic or legacy effect that you get this long-term improvement in your cardiovascular and microvascular outcomes. This slide again you have seen in the professor who presented to us, that every HbA1c in the first year, if you do not achieve glucose control, this is what you are looking at 5.5 years. A reduction in your myocardial infarction, an increment in your myocardial infarction, stroke, heart failure, and all other cardiovascular endpoints by the percentages, as you can see. So it's significant to achieve early glycemic control. However, all the trials did not show the same, as we know. Again, presented by Dr. Hilda, the ACCORD trial actually showed an increased mortality. But this group of people was actually much older with many other complications, and the targets they were trying to achieve was much tighter. So that means that all our trials are not showing that all the agents and every patient should achieve an HbA1c of 6.5%. So we have to look at how low we can go, and this is through the HbA1c individualized targets. And I think you guys have seen these slides like so many times, so I'll not deliberate on them much, but you have to individualize based on the duration of diabetes, based on the complications the patient has, based on how willing your patient is to change. It's not only about us giving them medical therapy and telling them, we want you to achieve, but you have to look at what the patient's intentions are as well. And this is another slide that was kind of shown again earlier with the different agents, how much HbA1c reduction you can get. On average, most of the oral agents that we have actually can give you a reduction of up to 1.5 at most percentage, with I'm including GLP-1 as well. But insulin has a higher reduction with no specific ceiling effect. So we know that we want to achieve glycemic goals, glycemic targets, but there are challenges, right? The biggest challenge is who? Who can tell me? It's you, me, the physician, the healthcare provider. The biggest issue we have is clinical inertia. And that's what we need to try and see how to break. That's why we're all here. Physician-related factors. You want to go to a treat-to-failure approach. So you treat your patient, give one agent, wait for the HbA1c to go up, you add another agent, wait, you add. So that's one of the aspects. And also we fear adding or increasing our drugs that we give, right? Medication-related. Of course, if I tell the patient to take 3 drugs at a go, 3 different drugs, the patient will be like, what is this, yeah? So it is the pill burden that is there, the cost of the medication and other factors, the fear of side effects as well, and then the patient-related factors. the aspect of the patient's willingness. Today we were having an excellent session on communication. So how well we communicate to our patient can overcome a lot of these barriers as well, actually. And we have seen through studies as presented today already that traditional approach of add-on actually does not do too well. For example, in the UK PDS, well, they were using sulfonylureas, but when you add it, you drop the HbA1c very nicely. But what happens? HbA1c starts to increase. Now you add another agent. Remember, with every increase in HbA1c, as we said, there's an increase in your cardiovascular mortality. Okay, so you are letting them reach there, then you are bringing down the HbA1c. But what about the micro and macrovascular damage that you have already achieved? So you have to look at that aspect. So that's where the role of early combination therapies then comes in. And we definitely need a paradigm shift in our approach towards managing hypoglycemia in adults with newly diagnosed diabetes and also those with existing diabetes. And that's where the element of early combination therapy approach comes in based on what we have discussed in the pathophysiology of diabetes. So how do we do that? Again, going back to our pathophysiology. Now we are blessed to have molecules which can address multiple pathophysiologic processes. For example, metformin would address your insulin resistance and also have some impact on your colon microbiome, right? Whereas if you give incretin-based therapies like the GLP-1 receptor agonists or the DPP-4 inhibitors, you would be addressing all these other pathophysiologic processes related to your alpha cell defect, your beta cell defect, your incretin effect, brain appetite and regulation. All these effects can be controlled by adding an agent, for example, to metformin. And also look at the kidney. You'd be, with your SGLT2 inhibitor combinations, imagine if you have dual or triple therapeutic combinations, you could be addressing a lot more pathophysiologic processes right from the beginning, right? So this is just a figure to show us how the different therapies fail at long term, like about 5 years of therapy. And you can see sulfonylureas have the highest rate of failure at about 1/3 of the patients who are on it tend to fail with sulfonylurea therapy if you are giving it as monotherapy. And this is what we are talking about at a rate of about 4% per year. And one thing that we want to understand is adherence. We can see that in patients with type 2 diabetes, adherence is anyway a problem. Remember, they are not only taking your diabetes medication, these patients are also on statins. These patients are on antihypertensives. They have osteoarthritis, osteoporosis. Some have asthma. They are on other agents. They have malignancies. So there is that whole aspect of pill burden which could interfere with their adherence. And this is what I'm talking about as far as the pill burden is concerned. So these are the things that we need to look at. And that's where the role of the FDCs or the fixed drug combinations comes in, as seen in this meta-analysis which actually showed a much better adherence and reduction in HbA1c when fixed drug combinations were used compared to giving the drugs individually. Okay, so now we have got newer agents of drugs, classes of drugs, and we have heard a lot about it today. So again, we'll browse through. So basically, the newer classes are now having less hypoglycemic effects, improved glycemic controls, yet they have got actually benefits beyond just the sugar control. And that's what we need to be looking at as we are prescribing therapies in our patients with diabetes. So like for example, let's start with the DPP-4 inhibitor. We know it has got multiple roles basically by inhibition of your DPP-4 enzyme. So that's what they are, DPP-4 inhibitors, and DPP-4 degrades incretins. So if you give the inhibitor, you have more incretin and it has all the benefits that you have of incretins, which is on the alpha cells and the beta cells of the pancreas, and you can see the impact on glucagon and insulin production. Now there are some smaller studies which actually showed significant potential benefits of sitagliptin. And this is to reduce your myocardial infarct size, to reduce atherosclerotic plaque, to reduce triglycerides, amongst other benefits cardiovascular-wise. And because of these benefits that they were seeing, including this study which shows reduction in internal carotid atherosclerosis, but these were smaller studies. And so this was followed up by the TCOS trial, which actually was a cardiovascular outcome trial that was discussed today morning. And the TCOS actually showed no specific superiority, but it showed that sitagliptin was safe, well tolerated with low risk of hypoglycemia, and achieved good sugar control, although that was not the primary outcome to be measured. So it was a beneficial agent without causing risk, basically. Yeah? and not associated with increased cardiovascular mortality. How about we look at the SGLT2 inhibitors? Dr. Khalda has talked quite a bit about it, so I'll not go again into the details, but this is what I was discussing about in the morning. There is SGLT1 and SGLT2 receptors in the kidneys, and SGLT1 is more in the stomach or the intestine, sorry, and the SGLT2 is more in the kidneys. So this, I think, is very clear. We explained this in detail. So when you give your SGLT2 inhibitors, you are basically reversing or trying to target all these pathophysiologic processes with the hemodynamic derangements that I talked about earlier. And that is on the heart. You can see the benefits. It's kind of reversing the hemodynamics we talked about on the kidney and on the vasculature, and thereby giving us improved cardiovascular and renal outcomes when we are using these drugs alone or in combination. And these studies, again, Khalda talked about them, DECLARE with the dapagliflozin, the DAPA heart failure, and the DAPA CKD, which showed significant improvements in both the primary and the secondary outcomes, as you can see there. So then now we should have a paradigm shift in management of diabetes, moving from a glucocentric approach and an only HbA1c targeted approach to going towards a person-centric approach. But do not forget the HbA1c even in that kind of an approach. Just that along with A1c lowering, you also look at the patient holistically, looking at the risk factors, looking at the complications and the comorbidities that the patients have. And that's where you want to target multiple pathophysiologic processes. So if you're giving a combination, for example, sitagliptin, dapagliflozin, and metformin, you realize that it targets the multiple pathophysiologic processes that we talked about in your diabetes pathophysiology. So what do the guidelines say then? Have the guidelines shifted? If this is what we are saying. So guidelines, there are many. Both the American Association of Clinical Endocrinologists and the ADA guidelines, I'll not go into the detail. Dr. Njenga and we had this discussion earlier on how to individualize therapy. But what the guidelines are recommending is when your A1C is above 1.5% above the glycemic goals, you can actually start dual combination therapy early on in the beginning, even at diagnosis. If your A1C, let's say you set a target for a patient that you need to be in an A1C, have a A1C of 7, your patient comes with an A1C of 8.5, for example, you can actually start early combination right from the beginning, from diagnosis, as we also heard from the VERIFY trial with early vildagliptin combination. So early combination therapy can be considered in some individuals at treatment initiation to extend the time to treatment failure. Now these studies for triple combinations have also come up, and hopefully they'll also be incorporated into the guidelines as we move on. So then that brings us to the role of triple therapy combinations. So there's this one study which is a 24-week randomized double-blind study which actually showed that in patients who are already on dapagliflozin, adding dapagliflozin to patients who are on sitagliptin with or without metformin actually significantly improved their HbA1c levels, was well tolerated and achieved clinically meaningful weight loss and glycemic targets compared to either agent alone. So the other study that we have now, this was actually a study conducted by Sun Pharma, which is a very interesting study. I would suggest you could read it. It's now looking at the fixed dose combination of these three agents, dapagliflozin, sitagliptin, and metformin, and comparing it to sitagliptin, metformin, and dapagliflozin, metformin combinations. And they found a significant change in HbA1c at both 12 weeks and 16 weeks in all the three groups. But there was a statistically significantly better improvement in the triple combination compared to the dual combination therapies. Same was the effect on the fasting plasma glucose and postprandial glucose, and all these differences were statistically significant, as you can see with the p-values. There was also secondarily now they assessed for other outcomes like A1C reduction to less than 7% at week 16, and they still found significantly better results with the triple combination compared to any one of the dual therapies. They did not find any significant changes in weight somehow in the study, but their mean weight was actually already very on the lower side. When they looked at the side effect profile, they found that the triple combination therapy, which was once a day, so it was 10 milligrams of DAPA, 100 milligrams of sita plus metformin extended release, either 500 or 1000 milligrams, and they did not find any significantly worse adverse effects in any of the 3 groups. So what we conclude with that study is that the triple FDC of DAPA, sita, and metformin extended release in patients with type 2 diabetes who are poorly controlled on metformin alone actually leads to better A1C reduction and a greater proportion of patients achieving hemoglobin A1C less than 7% in comparison to dual therapies. And this was achieved without any increased risk of hypoglycemia or weight gain. So who are the patient profiles who you want to give this triple combination therapy? You can't start every patient that comes to your clinic on the triple therapy, right? I mean, that's already an increased side effect burden you're having. So you have to still stratify your patients and individualize them. So like I said, if your patients are having high HbA1c levels, like more than 8 to 9%, especially if they are already on dual therapy, it's good to change them to a triple combination therapy rather than adding a third agent separately. To reduce the pill burden in type 2 diabetes, you can add, who are like, let's say a patient is on SGLT2 and DPP4, switch them to the triple combination if you need to better control their sugars or achieve cardiovascular benefits. So in patients who have poorly controlled diabetes but also have atherosclerotic cardiovascular disease, CKD, you could actually initiate them on the triple combination therapy, and as already talked about the higher HbA1c levels. Remember one thing, as we talk about all these drugs, which you have been hearing about since morning, the different therapeutic options, one thing we must never forget is diabetes is not only about sugar control. It's about controlling your cholesterol levels, it's about controlling your blood pressures, it's about controlling the social determinants of health, taking them into consideration, the mental health of the patient, and it's not only you and the patient. Diabetes affects families, it affects the community. So you have to deal with it in a much bigger manner, in a multidisciplinary team approach, as you can see here. So then what we are saying is type 2 diabetes is complex, it's progressive, and combination therapy is commonly required in management of type 2 diabetes. And we need to change our mindset from the current stepwise necessarily approach to a more holistic approach with early combination therapy in mind, looking at the patient as a whole, looking at their glycemic control, looking at their risk factor profiles, looking at their adherence, looking at what they can afford, and also looking at their cardiovascular and renal complications or elements that they have. Reduced pill burden actually allows us to improve adherence in our patients, and adherence improves about up to 23% if you're giving fixed dose combinations compared to single agent therapies that we usually do. So you can see the triple combination can be considered early in uncontrolled glycemia, patients with atherosclerotic heart, cardiovascular disease, heart failure, and renal risks. So to conclude, and what you're going to take home is there is a high pill burden and complex regimen with diabetes with reduced adherence, which we can actually improve by giving fixed dose combination therapies early on if we can. And we have the potential to reduce the risk of complications, because of course if your patient is adherent to therapy, the risk of further worsening of complications reduces. So this is what we are saying, that we should try to target therapies which have synergistic effects, looking at the pathophysiology of type 2 diabetes. And when we look at the trial that I've talked about, the combination actually showed to be quite good and improve and significantly better than giving dual therapies in isolation in patients who are not well controlled only on metformin. So what we are concluding is that fixed dose combinations of DAPA, sita, and metformin would be useful in patients to achieve glycemic control with increased patient adherence by reducing their pill burden. And so do not treat to failure, treat to target. Be this doctor. Thank you.
Thank you very much, Saira. I don't know whether there's anyone in the audience with a question, comment, contribution. Kelly, anyone? You have a question? Yes, Rosie.
Thanks, Saira. That was excellent. This is actually going to be a game changer because, like you're saying, in terms of, we keep on adding and that increases the pill burden. My only question is, if you need to adjust doses, how would you do that with this triple combination? So I think what we need to know is which kind of patients would you want to target when you're saying we do this triple? Can you start it at the outset? Or would you start with single, then combination, then you get to triple combination, and then in terms of adjustment?
Yeah, that's an excellent question, and that was basically the gist of the talk. It's like I said, not everyone can be started on a triple combination therapy, and so you have to individualize. Of course, this is one of the triple combinations. We'll see more and more coming in including, already we know about some triple combinations in the market, like we used to have metformin with pioglitazone with glibenclamide combinations. They used to be there already. So now these are modified combinations taking in the cardiovascular risk profiling and renal in mind, yeah? So it's like you have to really individualize your patient, I believe. So from the beginning, if your A1C is, let's say, 9%, and your patient has already got atherosclerotic cardiovascular disease, and you anyway would probably give a combination therapy of the 3 drugs, considering you want to achieve good glycemic control early, safely, with less cost and with improved adherence, then that's a good combination that you would probably put your patient on, or CKD, and you are having, HbA1cs which are on the higher side. You would probably start off early with the triple combination. Anyway, if you have a heart failure, for example, you're not even going to consider whether your HbA1c is high or low. You still would put the patient on the SGLT2 inhibitors, for example. If you have atherosclerotic cardiovascular disease, you'd put your patient on a GLP-1 receptor agonist anyway. Yeah, so I think you have to still individualize therapy. I think we'll...
Okay, I would like to invite Kalda and Dr. Kiran to give their comments. If you've had any experience with any of these triple combination therapies, we'd like to hear from you.
So as they're coming up, I've had an experience with triple combination therapies, and I've realized, especially in our elderly patients who tend to forget sometimes, it's somehow much easier to get them to be more compliant on the therapies. We do have some products already that have been there, and this is one additional, armamentarium that we have to our whole, a lot of diabetic medications that we are having right now. And I think one thing that I've really seen is adherence really improves with the elderly, especially patients. It would be good to hear from my colleagues.
Yes. Good evening, colleagues. Yeah, my name is Dr. Mwazo. I'm a cardiologist based in Mombasa. I want to really take this opportunity to welcome you to Mombasa. And I also want to thank Sun Pharma for inviting me, and Kdsg for inviting me to be with you this evening. I thank God that if it was only HbA1c that was determining many things, maybe today we'll not be here with you. After 2008, now physicians cardiologists and diabetologists, we are meeting a lot more often because you gave us a lifeline on which we are hanging onto. And I really want to thank you for your very excellent talk tonight. I like the passion and I like the insight into everything. So we share a lot, and probably mine would be just to say that I like the idea because of a triple combination, because as you've seen, it's a patient that we share. The patient that you are seeing as an endocrinologist, diabetologist, is the patient I'm seeing because they have all these comorbidities, including heart failure. And from me, if they have heart failure with reduced ejection fraction, the minimum number of pills is the 4 pillars and probably a device on top. So having a drug like this for sure is godsend, because if I have 4 that I'm giving them, they have a device, they have anticoagulants on top, they're on statins, and then I have to give them 3 different individuals antidiabetics. For sure, that is one of the greatest reasons why we really never get to achieve the targets that you are saying. So for me, it's really exciting, and I just want to ask you, maybe in your experience, this is a relatively new drug. What is the uptake? One question was asked here, how do you uptitrate? And I like the answer that you stratify on the basis of the hemoglobin A1C. But telling apart what is causing what problems in the midst of all that combination, I don't know whether you have something to say.
Yeah, so I have a few patients on this particular combination. It's just come in the market, honestly. So it's not too many patients that I can talk about, but it's a good combination in the sense, like we said, with adherence. But I agree with you. One challenge that we probably will face is the titration. But titration, when you look at it, if you look at all these combinations, they have multiple options available. So you can actually see if your fasting sugar is an issue still, let's say your HbA1c is a bit borderline high, after you have given it, you do your HbA1c again, you're still not achieving target, you could either decide to go to, like let's say if you started with a combination of 10 of DAPA with 50 of SITA and 500 of metformin, you could still have room for up titration in that case, okay? If need be, you could add another metformin now at night probably as an extra dose, because you have still not yet reached the highest dose of metformin as per the combination, even if you're giving to your 10 of DAPA, 100 of SITA and 1000 extended release of metformin. But what was interesting is that when they changed even patients who were taking twice a day metformin to once a day this fixed dose combination, patients' HbA1c is actually improved significantly with less side effects and better adherence. Although they were not really assessing adherence in this case, but the HbA1c is definitely improved.
Okay, so thanks, Sarah. I mean, that was really inspiring talk, actually, because you get to see everything put together, so that's really excellent. Thank you. From nephrology perspective, of course, we are the users of combination, fixed dose combination. I mean, think about your medications and yours, and then add on support for renal, and we take on, you know, all of the things that we were talking about earlier. However, with this combination, of course, we need renal dosing, so this is not our drug, to be honest. By the time you're sending to nephrology, we are down titrating on metformin. Maybe by the time your GFR is less than 45, you probably want to step down on metformin to about maybe the 500. So, but the thing to remember over here is that, remember that we can have a GFR that's perfect, but patient is albuminuric. So this is that patient that's going to benefit from that. And we very rarely get to see those patients, actually. We get to see patients when they're really quite badly off, and we would like to see them very early on in disease. But the thing I want us to remember, I'm so pro this medication, because if anything is going to improve HbA1c, and if anything is going to give us the sort of pleiotropic effects that we have been talking about, that we can see over here, then this is definitely a medication that we want to start early. And I want us to remember that there is no diabetic patient, I'm not supposed to say that, there is no patient with diabetes, yes, there's no person living with diabetes who does not have another comorbidity, especially by the time you're seeing CKD. If you have CKD in any way, and that means a GFR of 100, but microalbuminuria, you have an ACR of 35, you already have inflammation in the background. We've been talking about more and more about the pathogenesis and the role of fibrosis and the role of inflammation, the role of all of these things in the background, not just what we are seeing in terms of sugars and proteinuria and the like. So what are the other things within the spectrum of pathogenesis that we can moderate with? So if you have CKD, you definitely are a vasculopath. You definitely in diabetes have an angiopathy somewhere else. Your vessels are not good, whether it's in the eyes, whether it's in the heart, whether you have cardiac fibrosis, whether you have vascular endothelial issues. And all of these need to be addressed really, really early. So for me to start medications, even if it is in lower doses earlier on, and as you were saying, just tighten your HbA1c, we're really hoping as nephrologists, we just don't get any patients. We're really hoping we're out of business soon. We don't like our business.
Yeah, your tomato business will start thriving, clearly. Okay. Any further questions? I think you all are pretty tired, but we will be seeing, one thing I must say is you'll be seeing more and more of these combination therapies coming in. I think Dr. Gaman has a question.
It's more of a comment, and I mean, lovely talk. I really enjoyed the interaction.
Thank you.
When would you not want to use these combinations? Because we have an audience here that have people who may not have used these drugs before. Would you look at A1C levels, how the patient is doing? Are they, volume depleted? The risk here I'm looking at is euglycemic ketosis or ketosis from an SGLT2, and someone coming really sick and we are thinking that this patient, this will sort out everything. That's one thing. Then how the issue of pyelonephritis and the SGLT2. When would you say, okay, we've had enough of these UTIs or fungal mycosis or someone with a suprapubic catheter? When would you say, here, maybe not?
You want to start with the second one? You actually in your talk you mentioned you recommend it for chronic pyelonephritis. I didn't have the chance to ask. Now is the right time. Thank you, Dr. Gaman.
Interestingly, so for me, we always have to think about our patients in totality. What we are doing is we are working on wellness. We are working on health, not just numbers. So that even if you see your patient with diabetes and kidney disease, they have so much else going on in their body. So you have to think about how much damage you're causing. Your patient needs to be alive and your patient needs to be out of hospital. So usually we have one episode of UTI or pyelonephritis. You hope it doesn't get that serious, and then you treat. You work on hydration, you work on hygiene, you work on what you can modify. Sometimes you put on a prophylaxis. You really want to give the patient this benefit. But if you get a second UTI, many times, especially something that's ascending upwards, I wouldn't wait for another one, depending on what other comorbidities the patient has. I have a patient who, and this is so interesting, in terms of the various phenotypes that you see in diabetes. There's the young patient, there's the older patient, there's one with very aggressive disease, there's one that's just really mild. And I had one patient who we couldn't get rid of the UTI, and the patient's getting sick, and she has very bad diabetic kidney disease. And this is somebody who, at that point, I would have wished for something like finerenone, because she could have afforded it, but I didn't have it in the market. And I stopped the SGLT2 inhibitor. And it's not that it particularly helped her with the UTIs, by the way, she was totally colonized. But now I couldn't have something that's making her sick. That will cause renal function to deteriorate faster, because we have the implications of ongoing inflammation and the implications of everything else, their sepsis. Interestingly, within the cohort of EMPA kidney, there was a cohort that had chronic pyelonephritis, and this patients, rather than what we think in terms of sick day rules, where with sick day rules, we would tell our patients, if you have fever, dehydration, if you have diarrhea or any other form of fluid depletion or loss, you need to stop your SGLT2 inhibitor, you need to stop your metformin, you need to stop your diuretic, at least until this is resolved, and allow tubuloglomerular feedback to kick back in. This is what we would say, but these patients didn't, and they came in with chronic pyelonephritis, and somehow they did better than the ones that didn't have the drug, which was interesting. However, caveat, please do not put your patients with chronic pyelonephritis on an SGLT2 inhibitor. We will wait for more feedback coming in from that, and that's why I didn't put that in the slide.
And that was not the primary outcome anyway. I think that was an observation. But what I would like to say is, at least in my patients, what I've realized, if they get these recurrent UTIs, first of all, UTIs should be very rare with SGLT2 inhibitors. If they're hydrated well and they have good genital hygiene, genital or mycotic infections is more common. But what I have noticed is, if your patient is getting more than 2 UTIs, get a structural evaluation done. A lot of the time you'll see they've got reflux or they've got some kind of obstructive uropathy, which we many times do not assess for, and you take the patient out of the SGLT2 inhibitor, but you have not addressed the pathophysiology. So my patients, by the time they're getting more than 2 UTIs, of course, initially I'll hold the SGLT2 to see if that's the reason, but if they still get it, then definitely I'd want to get a urology review. Another thing you can do is try reducing the dose. Like if it's dapagliflozin, you can actually go to half the dose to 5 milligrams. We have available the option of 5 in the country as well. Another question that you asked, which was extremely crucial, is selection of patients when you are starting your triple combination therapies. So I'm not sending out the message that basically every patient with A1C more than 9 start on a triple combination. You have to look at your patient. For example, a patient coming in with sugars of 17, 18, 20. Honestly, I do not even start SGLT2 inhibitors at that point, especially if I have any suspicion of insulin depletion. Like if I'm suspecting the patient is having low insulin levels at that time, probably due to the glucotoxicity, like very high levels, then this is a patient I'd first bring the sugars down, even if I have to give insulin, especially in newly diagnosed patients. So in newly diagnosed patients, always look at the sugars at that time, check your urine before you are starting SGLT2 inhibitors. I do it as a routine. Because if they come with high sugars, you can still have ketosis anyway before you've even initiated your therapy. Actually, we have had patients who come in with and I was discussing that with someone today. There's a lot of ketosis-prone diabetes in our part of the world than we think. So our patients actually have type 2 diabetes. The patient has all the morphologic characteristics of type 2. You have an obese patient coming in, he's 35, 36 years old, and you have come in with DKA. Yeah, how many of you have seen such cases? And you put the patient on insulin. I've removed so much of insulin in a lot of these patients because they do not have type 2 diabetes, type 1 diabetes. This is type 2. So you have to be careful in those cases. And if your sugars are high, your patient has, catabolic features, where your patient has lost weight, and you check their urine, they have ketones, even if it's 1+, or they've got, significant 3+ glucosuria, that's not a patient you want to start on an SGLT2 immediately. Bring the sugars down. As per the guidelines, if your A1C anyway is above 10, you need to initiate insulin. If your sugars are above 20, you have to start insulin, and then probably initiate combination orals, which probably don't have the SGLT2, or in a patient with pancreatitis, for example, that's not a patient you want to start on this triple combination because of which drug? The DPP4 inhibitor. Incretin-based therapies are best avoided in patients who have got pancreatitis, because that's one of the side effects of your incretin-based therapies. So you'll avoid that in that kind of a patient. If my patient comes as AKI, acute kidney injury, that's not a patient I'll put on metformin, for example. Even the SGLT2, I'd wait for it to resolve at least, to stabilize, and then probably initiate the SGLT2 inhibitor.
I think, Dr. Saira, you are raising a very important point, because we have a mixed group here, that you always have to look at the patient before you. The idea of personalized medicine is very important. You have to have the patient before you. You have to really risk stratify this patient. In cardiology, we've got lots of risk scores. We are starting from the patient who's at risk. We don't wait until the patient has developed the overt clinical disease, and we're coming very late. So I think I have a question for both of you. For you as a diabetologist, so that you can choose the right therapy for this patient to prevent, complications, major adverse cardiac events, do you have like a risk score for your diabetic patient coming to the clinic to say, this one they will need this sort of treatment so that they do not get the complications? And also you as a nephrologist, are you actively using scores and trying to, so that our younger colleagues also maybe can learn? For example, I know for us in the area of heart failure, we use troponins, pro-BNP, but I know urine albumin-creatinine ratio also is very, very prognostic. Maybe you can shed some light. Would you use that to say this patient requires aggressive therapy, triple therapy, before it is too late?
So we have, of course, the 4-score kidney failure risk score, which gives us the possibilities of us ending up dialysis dependent or in kidney failure. within the next 2 years, within the next 5 years, within the next 10 years, which uses proteinuria, patient age, gender, and other comorbidities. It has not been validated for our population, and we find that phenotypically our population is a little bit different, but we do try to treat our symptoms in our patients. We do know that proteinuric diabetic nephropathy is of course worse than non-proteinuric in terms of the outcome. So for us, that's a very big red flag if any patient was proteinuric. What we usually find though is that many patients out there have been having a creatinine done, but no urinalysis, no microalbumin, or by the time people are noticing, we are already on a urinalysis with trace, proteinuria, and then people say, oh, that's trace, that's probably nothing. And then the next time they come in, that's proteinuria of 1+, and 1+ proteinuria is already macroalbuminuria. That means we've missed our window. We've actually missed our window, and we have lost a lot of functional renal reserve. So I would advise the first thing before we start calculating kidney failure risk score, which is looking at UACR or macroalbuminuria, everybody needs to check all diabetic patients for microalbumin. And if you have anything greater than 30 or 3, depending on your value, then you have something to worry about.
Excellent. We don't have specific risk scores to say this patient scores 3, so you start on metformin, this person. Like I said, it has to be extremely, diabetes is very individualized. There's no extreme right or wrong. You have to look at the glycemia, you have to look at the comorbidities, look at the complications, but very importantly, social determinants of health, especially in our part of the world. You have to look at their cost, look at their affordability and long-term sustainability as well. We have fancy drugs we have talked about today, amazing drugs, and in our setup we can afford to, or our patients can afford to use them. But again, even in our setup at Aga Khan or in the private sector, how many can afford to use that long term? That's the question you have to ask and discuss with the patient before we are initiating them. So I think there's a lot more around diabetes care than simple risk, putting them in kind of pockets.
Yeah, so what is the bare minimum that you'd have in a diabetic clinic, in a nephrology clinic? In our clinics, we have oncobrachial index, sort of trying, and many other parameters. We have the ECGs, the echoes, this is all sort of trying to gather data to see in which space to put this individual patient. I would like to hear from you, what is the bare minimum that a modern diabetic clinic?
Yeah, that's a good question. That's a very good question.
What's the effort you put in to just catch these patients early to make sure that we are not...
That they do not go into complications early.
Yeah.
So, I mean, ideally in a like the right kind of setup, the minimum, bare minimum, first of all is your team. Even more important than the equipment, I believe, is the team. You need at least yourself as the diabetes, like as the endocrinologist, as the physician or the primary care provider, with a nutritionist, I believe is extremely core, a diabetes educator. To start off, I think these 3 are extremely important. And then you would have counseling services, at least once a diagnosis and where needed. Another very important element that we leave out, very easily we leave out, most of our clinics do not have counseling referral systems, and that's extremely crucial in any diabetes care unit that you're dealing with. And then of course there's the extended team that you look at, the podiatrist, very crucial for the foot. You have the vascular surgeon. So like in a facility which is now a tertiary level, then you have the availability of all that. But in the clinic, as far as equipment is concerned, at least bare minimum, you need at least a monofilament, and a tuning fork. If you have these 2 devices, the rest, a lot of the work is done by your fingers. Agreed or not? You could have now additional equipment like an ECG where you don't have another place where if it's just the clinic. You could have an ABI, you could have a handheld Doppler for foot evaluation. So bare minimum, I think if you even have just a basic monofilament and a tuning fork, a lot of the work is done by your hands if you do it correctly. Maybe I'd like Dr. Gaman, he has a comprehensive diabetes clinic as well. He could add if there's nothing that I've missed.
I think a point of KA1C, a point of KA1C. So you're not sending anyone out. In 2 minutes, you know what their A1C is. Point of care is coming up much more. Point of care, the equipment, the team. I think the difference is here you have blood sugar being influenced by 7 different variables. So imagine a mathematical equation being influenced by 7 different variables. It's very hard for me to put you in this class. So there are 7 different variables. How much, what you're eating, what medications you're on, what hormonal effects, infection, stress, peer pressure, when you go now with, so those are variables that you need to include in the pocket when you're trying to classify someone. So as she said, we have those basic guidelines. If the A1C is above 10, you need to start insulin. If your A1C is 8 or so, you need to be on dual or therapy. So there are some basic guidelines. Then there's the social factors that you need to look, what can they afford. So we have, she presented a table or that gives several factors, but it's not easy. Each patient, as they walk in, you say, this one is a minimal insulin patient, this one a minimal cost, this one is an all-out patient. As they are walking in, that's the math comes in like this. So that's what it is. Then, to answer you guys, tomorrow I'll talk about continuous ketone monitors. Maybe that will sort the issue we are having now of having an SGL2 with your patient with pyelonephritis.
So I'll just give you a small story. There's actually one of my pediatric colleagues where I was previously working, and he told me, for you guys, it must be very easy. You can even just tape record the same message for every patient, who comes in with diabetes, because you're just managing diabetes. It's just sugars. So you can even just record your message and, play it for every patient. But really, is that what diabetes is about? Today we are learning it's a lot more than that. I think we have exceeded our time, or we have reached time up now. So thank you very much to my panelists.
Yes, thank you very much for all that. The nephros can talk about the tubules all day long. So, Soki, thank you very much. Wazo, you've smothered us with love. Saira, you've killed us with sweetness. So before we go for supper, no, sorry, it's dinner. It's not supper. Supper is different. So before we go for dinner, I would like to invite our sponsor, Wafadhili Wetu. The food you're going to eat is courtesy of Wafadhili Wetu. That's the Swahili word for sponsor. So Joy is going to give us a 5-minute talk before we go for food. Thank you so much.
Hello, good evening. My name is Nyawera Muriuki, or Joy, from Sun Pharma Marketing Department. Thank you so much, Dr. Saira, for that informative talk. Thank you so much, our panelists, Dr. Karen Mozo and Dr. Soki Kalida, as well as eminent moderator, Dr. Irene Jerry. Thank you so much. Mine is to just place emphasis on this novel combination that we actually believe is transforming how we perceive the management of diabetes. The combination is available as dapagliflozin 10 mg, sitagliptin 100 mg, and metformin 500 mg extended release, as well as metformin 1000 mg extended release, making it a truly OD dosing formulation. This is very, very ideal, I think, and rational. As a cardiologist, I believe HFrEF patients living with diabetes is an ideal formulation, rational to actually prescribe in that patient group, diabetic patients with ASCVD, uncontrolled diabetes that is presenting itself with more than 1.5% above the goal, and also CKD for as long as the eGFR actually allows. All these coming at a price of 1,600 bob for the 500 mg metformin and 1,900 shillings for the 1,000 mg metformin. This is quite a gem in terms of pricing, because even if you were to prescribe metformin and sitagliptin independently and then have to add dapagliflozin on the side, nothing beats the cost of dapagliflozin. That alongside, we also have other products like oziclidemar, glycoside modified release, our statin range as to Rosavel. Also, we now have launched Rosavel 40, the very first rosuvastatin 40 mg in the market, scores over atorvastatin 80. You will receive better results with Rosavel 40 within a shorter time frame, actually way better than atorvastatin 80 milligram. Again, I think very recently the guidelines may have changed for very high-risk patients from working towards the goal of 70 milligram per deciliter to around 55, and you can only achieve that with a high intensity like Rosabelle 40. We also have Duzela, good for DPNP, and we also have Irovel, the only ARB you can trust with renal protection. Thank you so much for this session. Thank you so much, Dr. Irene. We look forward to your continuous support. Thank you.
Thank you so much. Rosie, I don't know that you have any announcements before I send people over for dinner.
Irene, you said wafadhili wetu. At least I've realized I don't know Kiswahili. I have learned something today. Dr. Mazo, don't laugh at us. We will learn by the end of this conference. Vile mnaongea watu wa bara ni ngumu. So thank you so much. We really want to thank you for your indulgence. I know it's been a really long day, and for that we are going to feed you. This dinner is sponsored by Sun Pharma. We really want to thank you. Dilraj, maybe you stand up and wave. He's always been very supportive for Kdsg, so we really want to thank you for taking the time, and the fact that your brands are now moving towards the diabetes range is very exciting. So you're going to get your dinner vouchers as you exit the room, right? Towards the dinner area. And that is only for people who are staying outside of Pride Inn. If you're staying here because your sponsors have actually paid for it, please don't pick a voucher. We are paying for the people who are staying outside of Pride Inn. You can go and enjoy your dinner with a drink. And remember, tomorrow we start at 8:30 sharp. We've got an even longer day because we'll top it off with our gala dinner. Kindly, tomorrow is the gala dinner. The theme is Swahili night. I will be the bodyguard that stands at the door and will not allow you if you're not dressed appropriately. Don't come and embarrass us. We have to show watu wa bara. Hata sisi vile tumetoka Nairobi tunajua, sio? So please, if you have time, make time between now and tomorrow morning to find an outfit, have it delivered, because tomorrow, bring it, tutaenjoy kweli. Sawa sawa, so thank you very much and welcome for dinner.
Even a lasso is okay. That's Costarian wear. Yes, you can wear a lasso. Bijikenda wear, Giriama wear. Thank you, people.